I'm Dr. Ronald Berkman. Today we'll be reviewing minor gynecologic procedures with our focus being on endometrial biopsy and uterine curettage. This is part of a three-part series of videos, three different videos, followed by a discussion session with the goals of this particular video as outlined in yellow. That is, following this video, participants should be able to list the indications for endometrial biopsy, dilatation and curettage, as well as suction curettage. They should be able to discuss the use of various instruments for uterine curettage or sampling, as well as list the risks and complications of the use of curettage procedures. The first part will deal with endometrial sampling, and there are a wide variety of indications for endometrial sampling, better known as endometrial biopsy. Obviously, the most important indication is abnormal uterine bleeding. Certainly, all of us understand that postmenopausal bleeding, which would include spotting or even brown staining, is an indication potentially for endometrial sampling. In women who are age 45 to the menopause, bleeding that is more frequent, heavier, more prolonged than usual also may be an indication. In women who are less than age 45, abnormal bleeding in so-called high-risk women, and this would include obese women, women with chronic anovulatory states such as PCOS, or bleeding after secondary amenorrhea, as well as the presence of the Lynch syndrome. Further, persistent bleeding despite medical management would also be an indication for sampling in an individual less than age 45. Also, monitoring women with uterine bleeding due to endometrial hyperplasia is another reason for doing sampling. And finally, one also would do a sampling procedure prior to performing an endometrial ablation in order to ascertain for sure that one is not dealing with an endometrial cancer. In addition, abnormal cervical cytology also can be an indication, particularly when atypical glandular cells are noted. If this felt to be endometrial, basically in all women age 35 or greater, particularly if they have risk factors for endometrial cancer, all of these women would deserve sampling. In fact, the people who have risk factors for endometrial cancer probably need to be sampled regardless of their age. Finally, the presence of endometrial cells in women age 45 or greater with abnormal bleeding is another reason for doing endometrial sampling. So, the basic technique is an endometrial biopsy. Usually this can be performed without use of local anesthesia, cervical dilation, or many times without use of a tenaculum. You prep the external cervix with some antiseptic. You advance the device that you're using to the fundus and note the depth. Most sampling devices have markings every centimeter. And then you apply suction by pulling back on the so-called plunger and move the device in a to and fro motion, as well as rotating it, such as with the Pipelle device. This usually will provide an adequate sample, usually with the first pass. However, if you do pull past the cervical os, you will lose suction. If that occurs, then you should expel any sample material into the collection cup, but keeping the device end sterile, and then reinsert and apply suction again if it appears that the sample that you already have obtained is inadequate. This particular slide demonstrates two sounding devices that could be used to assist in providing a small degree of cervical dilation so that you can insert your particular suction apparatus. The top one is the Flexisound. This also can be used as a means of assessing the depth of the uterus. And the bottom is the Osfinder, where again you can provide dilation in a graduated manner as you further insert the device into the cervix. This slide demonstrates two of the most widely used endometrial samplers. The top is the so-called Pipelle. Again, it is a very flexible device, has a plunger, so to speak, on the end that you pull back briskly once it's inserted to the fundus, and this provides a suction for removal of sample. The bottom is an endometrial sampler. This is different in that the actual device itself is more rigid and in many instances makes it easier to insert via a cervix that may have a small degree of stenosis or be tighter than some. Suction is applied with the use of the syringe that's attached to the end that does not enter the uterus. The indication for ultrasound imaging prior to doing endometrial biopsy again vary. Certainly, if you have scant postmenopausal bleeding, that is maybe only spotting or a brown staining, many times you can do an ultrasound, and if the endometrial thickness is less than 4 millimeters or even 4 millimeters, the risk of endometrial cancer is exceedingly low, and one does not need to do endometrial sampling at that time. However, if bleeding does recur in general, one should consider sampling with recurrent bleeding in this situation. With recurrent or persistent bleeding unresponsive to medical management, certainly one should consider doing imaging, particularly if one suspects a focal abnormality, such as a submucosal myoma or a polyp, as opposed to a more global process. Abnormal bleeding after a prior endometrial ablation is also a reason to do an ultrasound, because it may be difficult for you to locate where the bleeding is because of the disruption of the endometrial cavity. Certainly, pregnancy-related indications such as determination of gestational age or location of retained tissue are a reason also to do ultrasound prior to any curettage procedure. And also one can do ultrasound for guidance whether there is a suspected stenotic os in order to aid in determining the true course of the cervical canal. Specific indications for a dilation and curettage procedure are listed here. First is the inability to perform an office-based procedure. Either the patient is unable to tolerate the procedure, or there's a degree of cervical stenosis, such as the instruments I just described cannot be inserted in the uterine cavity. It also may be a reason because of insufficient tissue for analysis following an office-based procedure, or a non-diagnostic sample in women at high risk for endometrial cancer. One also would consider this procedure if there's persistent abnormal bleeding in a woman with benign findings on an office-based procedure, again raising concern that perhaps you missed a focal area, and with concomitant procedures such as hysteroscopy or laparoscopy. This briefly outlines the steps of the D&C. Obviously, you place the position in a dorsolathiotomy position, you prep the vagina and the cervix. Paracervical block works very well in that most of these procedures can be done in conjunction with conscious sedation. After placing the paracervical block, you put a tenaculum on the cervix, exert traction to stabilize the uterus, but also to align the cervical canal, and then sound for both direction and depth, and then carefully dilate the cervix with dilators. And for a diagnostic procedure, you sample in a circumferential fashion with a sharp curette, and if the procedure is being performed for a retained placenta or postpartum hemorrhage, you can also use a ring or ovum forceps to extract tissue, and clearly would avoid vigorous curettage so one doesn't end up with a potential for an Asherman syndrome. Here, ultrasound can be helpful in locating the retained tissue. And finally, if you feel that there's a polyp, certainly the use of ovum forceps may help you in perhaps finding the polyp and removing it. This just demonstrates the placement of a paracervical block. Initially, one should put a small amount of anesthetic, and again, usually with diagnostic procedures, one would use only plain local anesthetic like 1% lidocaine. With some procedures where perhaps the cervix is felt to be more vascular, one could also add dilute epinephrine to the lidocaine solution. Placing a small amount of anesthetic at 12 o'clock allows one to apply a tenaculum there without causing undue discomfort for the patient, but also allows you to exert traction and stabilize the cervix for placement of at the additional sites, as shown here at 4 and 8 o'clock. This demonstrates two types of tenaculum. One of the most widely used tenaculum is a single-tooth tenaculum demonstrated at the top. The disadvantage of this particular tenaculum, however, particularly in pregnant women or women who are significantly postmenopausal, in that with traction, laceration of the cervix can occur. Now, this can be obviated to some extent by blunting the teeth, which is often done as well. The bottom tenaculum is basically can be a multiple tooth tenaculum or a long Alice clamp. This has multiple teeth, such that the chance of laceration, or the risk of laceration, is significantly reduced with the use of a tenaculum of this version. This slide demonstrates two of the most commonly types of dilators used for D&C. In particular, however, the Pratt dilators on the right have a more tapered end to them, and in many instances this helps facilitate cervical dilation without having to exert potentially more force than you wish. This demonstrates the correct hand position for inserting rigid dilators. The forefinger prevents inserting the instrument too far than you intend it to, and by either pressure down on the forefinger or tilting the wrist can direct instruments to their desired position once they enter the uterine cavity. This demonstrates at the top some uterine curettes. All of the shafts of most uterine curettes are malleable so that you can bend them into shape for, let's say, a retroflex or anteverted uterus and allow or facilitate curettage. And the bottom picture is that of an ovum forceps for removal of polyps or additional material, perhaps with a incomplete abortion procedure. This is just demonstrating the curettage of the wall of the uterus and noting that, again, the curette has a slight angulation to it, which facilitates doing the procedure. If you look at the complications of dilation and curettage, there can be immediate complications. Hemorrhage is certainly one of them, but this is much more frequent with pregnancy-related disorders or molar pregnancies, and occasionally need to be managed by packing or even high-dose estrogen in non-pregnancy related problems. Uterine perforation can occur. The fundal site is usually less concerning than the lateral site, and the determination of whether the procedure is complete, the patient is stable, or one suspects bowel injury determines really whether one needs to visualize the injury through laparoscopy or laparotomy. Cervical injury includes a laceration by the tenaculum or creation of a false channel. Delayed complications, occasionally hemorrhage due to retained tissue or with a false cervical channel. Infection can occur, but it's quite rare. And finally, you can have intrauterine adhesions or Asherman's syndrome due to denuding of the endometrium, especially with procedures for pregnancy-related conditions. So what are the indications for suction curettage or vacuum aspiration? Certainly, it's indicated for the management of first or second trimester miscarriage, including retained tissue after partial expulsion. Also for induced first trimester abortion, as well as part of a dilatation and evacuation procedure for second trimester abortion, and for the management of molar pregnancies. This just sort of lists the steps of the procedure. The difference here compared to a diagnostic dilatation and curettage is that oftentimes laminae are placed in advance to assist in the dilation of the cervix, particularly if it's not being done for incomplete abortion. And then one, after applying the paracervical block, dilates gently to the size that will fit the suction cannula. One should use a no-touch technique for dilation as well as insertion of the cannula, that is, not touching the tips or placing the dilators or the curettes against the vaginal wall or in any of the secretions of the vagina, because, again, procedures done related to pregnancy tend to carry greater risk for infection. And after the curettes are inserted, in general, one rotates them and uses a gentle to and fro motion. Once you determine that it is likely that the procedure is complete, and this usually is because you have a slight gritty feel in all quadrants, and in general you'll see some foamy bubbles appearing in the cannula, the procedure can be ended. Perhaps one quickly checks with a sharp curette to ensure that in fact there is no remaining tissue. This slide demonstrates two types of suction cannula. The top one tends to be rigid and has just a small lip. The bottom one has two lips and also is flexible. And in theory, these types of cannulas, the bottom one, may reduce the risk of uterine perforation. This demonstrates a manual vacuum aspiration system. This is a particularly useful system for managing women who've had a partial expulsion of products of conception who present to emergency department. In the past, all of these women, if they were bleeding or there was a concern that one needed to remove remaining tissue, they would have to be booked in an operating room, and oftentimes with inordinate delays to get the procedures done because of the emergent nature of other procedures that are scheduled. This allows aspiration to be done in many of these patients using a manual system without the necessity of more complex, shall we say, vacuum devices and the like. Basically, as shown here on the left, there is a large syringe with a pinch valve, which allows one to basically provide a suction, which is certainly useful, but also enough to remove most incomplete products. And then on the right are varying size of cannula to be used with the device. In addition, one can, with performance of DNCs, particularly suction DNCs, use Laminera, which can assist. This shows on the top a Dilapan S osmotic dilator, which is a manufactured dilator, so to speak, and is made from a hydrogel which absorbs fluid. And while B and C are two sizes of Laminera which are derived from seaweed. As shown here, the bottom shows what most of these Laminera would look before placement in the cervix, and the top one shows the Laminera which now has been dilated through absorption of fluid in the cervix. Of note, the Laminera also will provide some degree of mechanical dilation in addition to changes related to removal of the fluid in the cervix. This demonstrates the correct hand position for inserting dilators at a DNC or suction curettage procedure. This demonstrates also that you can vary where you put your tenaculum on the lip of the cervix. If you have a sharply anteverted uterus, you would leave it on the anterior lip, and then have angulated either dilators or even suction or curettes, which allow one to sort of reach the anterior flexed uterus. The bottom part of the diagram demonstrates placing the tenaculum on the posterior lip of the cervix, and with traction straightens out the uterus to some extent in the cervix. But again, instruments now are directed posterior because of this particular angulation. This is demonstrating the use of the flexible cannula system that I discussed just a minute ago. Here again, you produce the suction pulling back on the syringe, and then hold it using the a small device that is near where the cannula is, or the curettes are put, and by punching onto that, you can again turn on the suction. And here in the top of the slide shows these curettes being rotated with the uterine wall collapsing or contracting around the tip. And this just shows with rigid cannula, one rotates them and then brings them back toward the cervical os. In many instances, it's not necessary to go all the way to the top of the fundus to basically aspirate the contents. And this just shows a suction cannula aspirating tissue from the uterine wall. And here is a curette checking for completeness. Keep in mind that if this is a pregnancy-related condition, one just basically checks gently and does not do vigorous curettage in order to reduce the possibility of subsequent intrauterine adhesions, better known as Asherman syndrome. The steps in a D&E, primarily done for pregnancy termination, are quite similar to what we've already discussed. Here again, clearly laminaire are more frequently utilized. The cannula that you use may vary actually to even smaller than those listed here. Here it's listed as 12, 14, and 16. This is primarily for a more advanced gestational age. But basically your dilators should be of adequate size to allow insertion of these cannulas without significant force. And once the proper dilation has occurred, either under ultrasound or without ultrasound, evacuation occurs usually by rotating the cannula in the lower uterine segment to grasp tissue. Then one pulls the cannula out, again using a no-touch technique, and then can insert ovum forceps or similar to ovum forceps devices to grasp tissue and pull it through the cervical os. Again, you try to minimize how many different passes you make, and complete evacuation usually is evident when you no longer can feel any unusual attachments to the uterine wall, and also by inspecting the contents to identify fetal parts as well as placental tissue. With very early pregnancies, washing what tissue you obtain in water, or rinsing it rather, and then suspending it in water will often allow you to be reasonably assured that in fact you've been in the right place, and this is a truly pregnancy-related tissue in the uterus, as opposed perhaps of a concern perhaps of a ectopic pregnancy. As shown in the top, this is sort of the coarse and shaggy appearance of decidua, but and the bottom portion of the slide shows this sort of fluffy, feathery finger-like projections which are consistent with villi. So if you get tissue that shows this, you are reasonably sure that in fact the pregnancy that's been expelled, or that you've just done a D&C for because of a potential incomplete expulsion of contents, is in the uterus as opposed to an abnormal site. Complications of suction curettage, not terribly different from what we've discussed previously. You can have hemorrhage, but this here can be related to a whole variety of reasons, particularly with more advanced gestations if being done for pregnancy termination. You can have atony, you can have cervical laceration or perforation rather, and the management of all of this includes uteral tonics, manual compression, even intrauterine balloons, and occasional exploratory surgery. Cervical injury is usually superficial, but occasionally can be linear if there's a scarred cervix. Hematometra is sort of a specific complication of some suction curetages, in that a patient after having the procedure done will present with significant abdominal pain and have a uterus that is distended beyond what the uterus was when you had begun the uterine evacuation. This basically is treated by inserting again a suction curette and emptying the contents, which usually are consist of bloody fluid or just blood by itself, and by so doing this, essentially the complication is managed successfully, though one wants to be sure that they use uterine contractile agents after the evacuation occurs. Uterine perforation. Here again, you want to rule out damage of abdominal contents, especially if the perforation occurred with a suction cannula. And certainly you would be of concern of doing a laparoscopy also if the procedure is incomplete or there's excessive bleeding during the course of the procedure. Delayed complications include retained tissue and on occasion infection, though with the use of prophylactic antibiotics in most abortion procedures, the overall infection risk has declined substantially. So in conclusion, endometrial biopsy and uterine curettage procedures are the most common surgical procedures in gynecology, probably in terms of sheer volume. Most of these procedures can be accomplished, however, without use of general or spinal anesthesia. However, successful procedures using local or no anesthesia does require appropriate patient selection and appropriate gentle technique. Although complications are uncommon, with adherence to proper technique, early recognition reduces the likelihood of increased risk of long-term adverse outcomes.